Hi, Dr. Caine. So we have a new admission of a patient that presented for a suicide attempt. And since we have a few minutes between rounds, I was wondering if you can walk me through your thought process.
Well, I'd be glad to, Yuri. It's really important that we do this kind of thing and take a few minutes to try to put it in perspective because, well, to think of it, so many people come in with a very diverse range of suicide attempts, and we sort of use that label suicide attempt, but it can cover a very wide variety of events from something that may not be very threatening, even if the patient is in great distress, to something that was lethal. You know, the person was on the intensive care unit and is now here.
Yeah.
So I really approach this in, well, thinking about 5 different things. And I'll go through them sort of in sequence because this is really the way I kind of look at it. And the first thing I consider is implementation. What did the person do? And it's important to appreciate that there's a potential lethality in an action, a risk, if you would, but there's also a rescuability. The example I often give is that at 3 o'clock in the afternoon, if someone tries to jump off a bridge, the risk is going to be the same. You know, the river's there, or the current, or whatever, the height of the bridge. But at the same time, it's going to be very different if someone tries to jump from the same bridge at 3 in the morning. If someone takes a potentially lethal dose of, say, pills, available whatever, but does it in their own home and comes downstairs and other people are there and kind of admits that they've done this versus going to a motel where they check in with a name that's not theirs, pay cash, and basically hide. So risk and rescue are really very concrete indicators of what was going on. Now, obviously, in some ways, the second thing we want to link to that is ideation. What did they really have in mind? What were they thinking at the time that they made this attempt? You know, were they feeling hopeless and down in the dumps and worthless and saw no future for themselves and really kind of were so caught up in this tremendously bleak present that it was going to be that way for the rest of their lives, that they believed that this was, that way? Were they feeling worthless and had absolute self-doubt? Did they feel like they were a burden on others and that there was no way to really connect with anyone else, that they didn't have a sense of belonging? Nobody cared about them. Had they had really, what would we call it, very distressing recent life events that were such that it just seemed like this is the end. And so we really want to understand their outlook, what they were thinking, what they were feeling. Thoughts and feelings aren't the same thing, but they're highly related, and we really want to know both, and we want to get an understanding of that, and very clearly how that evolved in the hours, days, months, maybe even years before. Clearly, we want to understand whether they've had a prior attempt with similar thoughts and similar implementation, or was this really different in some ways? The third thing I think about is what I might call epidemiology. We know that suicide really varies across the life course. Men and women are very different in how they attempt suicide, what they die from. Of course, firearms are most common in men, although sadly women now are killing themselves with firearms more than any other method. But the most common method of attempt is taking pills and ingestion. And we want to know, well, man, woman, male, female, what age? You know, a person who's 17, their suicidal actions and behaviors are going to be very different from someone who's 47 or 57 or 77. And so it's really critical to understand, how does this person, whomever we're dealing with, match up in some ways with what we know are the lethal patterns of suicide across the life course. And so appreciating that gives us a better sense in some predictable way. Now, obviously, we want to be individually oriented and sort of person-centered, but we also want to understand how someone fits into these patterns. The fourth thing I think about is diagnosis. And diagnosis is complex because suicide cuts across all sorts of diagnostic boundaries, and we can see it with people with schizophrenia, with bipolar disorder, people suffering recurrent major depression or a single depressive episode, but also you may see it in someone who has a less severe depression, but their mood and how they feel about themselves and their thinking may be very down in the dumps, but they're not so paralyzed or slowed down as someone with a extraordinarily severe major depression, right? Where they're kind of moving slowly, thinking slowly. In fact, we know that sometimes people, as they improve in their depressive episode, may actually have greater potential because their psychomotor symptoms and all their thinking doesn't necessarily coalesce and coincide with their mood symptoms, and they may be more capable now, better ready to act. And just because you think they look better doesn't mean they always feel better. So we want to understand this. And, this is really true with many different diagnostic situations, and we can talk about that in more depth sometime. But another example, someone might be coming out of their most recent episode of psychosis associated with schizophrenia and now on meds, and look back and realize, well, gee, I've had 3 or 4 of these episodes now. I'm in my late 20s. And my friends and peers are getting married, they have jobs, and look at me. And demoralization may be a very powerful factor in this kind of thing. Now, last but certainly not least is my gut impression. And I want to be very clear about this. I try to assay my gut and ignore it. And the reason that I turn away from it, the reason I try to avoid it is because so many people give off signals that seem to be reassuring. I just gave the example of someone who's coming out of their severe mood disorder and they look better. And even during that time, their mood may fluctuate, and you may talk to them when they're feeling much better. But I remember a patient I had who went home and visited his apartment. It was a supervised visit, and he got to the place, it was a mess. He'd been living alone. This brought everything cascading back on him. Came back to the hospital as suicidal in his thinking at that moment. And thank heavens we had an escort and someone who brought him back. So we have to be very careful as we think about our intuitive responses. Adolescence, a common example of someone will make a suicide attempt, however lethal it is or isn't. They come to the emergency department, and by the time they walk in, oh, I'm fine, doc. There's no problem. I'll go home. And the parents say, you're grounded. And then they go off and make a much more serious attempt. Or you don't have your phone anymore, or you can't use your computer, or those things. So it's very important to hold one's intuitive response over here and ask, well, what is it about that I'm responding to? But think your way through the evaluation. It's a thoughtful, considered process. Now, there are other aspects which are tremendously important. Getting a really good history, finding out about someone's developmental trajectory, wherever they are in their life course, whether it's young, middle, or old. Appreciating whether there's not only a psychiatric history and other medical problems, which become very much triggers in suicide for some people, fears of cancer, as an example, or the presence of cancer, but also understanding family history, because other people may have died by suicide. It may be part of the family, I'll put it in quotes, vocabulary of how one thinks about, extraordinarily distressed times. So being an excellent clinician, thinking about all these things, evaluating whether there may be some, ongoing pathobiological, pathophysiological processes that may be contributing this are all part of this assessment. But these are the sort of the cornerstones of how I assess someone who's sitting in front of me now and I'm interviewing them and I'm trying to really appreciate, well, how come they're here now with this attempt, as I say, which may be very varied in its nature and its threat. Do you have questions for me?